Therapeutic Techniques Part 2, Good Mothering and Personal Revelations. In the following dialogue, Dr. Searles shares his thoughts on two techniques widely debated in the field, so-called good mothering, or supportiveness, and the use of personal revelations. The discussion proceeds from an audience question about the role of support.
The role of support. Now, of course, what you mean by support is immediately a question, and I'm not asking you, but I'm going to try to respond about this. What you mean by support, I would assume, is something in the realm of a reassuring kind of response, a relatively gentle response, maybe a confirming kind of response when you find the patient saying something that you feel warrants a kind of confirmation. Maybe as something in the realm of explanation. This would usually be called support in the psychotherapeutic sense. I can believe that these things have their role, all right. I tend to think of it as a fairly limited role, I will say. I don't think you have to be a tough guy all the time. These people certainly need gentleness. The question of my mind is how able are they to accept gentleness without getting paranoid about it. I would remind you that these people, like everyone else, are very troubled as to whether they have the capacity to give love, or in your terms, to be supportive to others. And if you can succeed in being supportive to your patient, being kind and friendly and in the usual sense of the word, that may all be very well, but it may only increase the patient's feelings of guilt about his own subjective inability to be supportive and confirming of other people in his life.
Another way of looking at support, or lack of it, has been seen by some therapists in terms of emotional deprivation.
Emotionally depriving impact of the therapist's silence. That gets back to the question of supportive treatment and whether supportive measures are sometimes called for. The emotional deprivation is a topic that it's hard for me to speak of only as confined to the matter of the therapist's silence. Because we have this fact in the borderline patients that most of them are either terribly mistrustful of their own emotions as being so unpredictable, so intense and unpredictably changing, or they are very afraid that they are basically unable to feel. Now, in the latter instance, they can stand and well use a lot of the therapist's being what would ordinarily be called emotionally depriving. Because if the patient is very, very troubled as to whether he himself is able to feel, and if his therapist is at the same time very much caught up in being warmly supportive and giving, it does tend to very painfully highlight the patient's feelings that he himself is incapable of this, that this is the very kind of thing he feels so painfully lacking in himself. And he is someone who is apt to get more relief than anything else from a therapist who is able to just be pretty much part of the woodwork most of the time and let the patient move more at his own pace in getting into this realm of feelings. One of the things that is most difficult about work with borderline patients is the intensity of the negative transference. I suppose it's fair to say that that's probably the most difficult aspect of the work. And these negative transference images include prominently among them images of the therapist as being a cruelly depriving mother, a mother who is ungiving and who wants the child to die and waste away rather than to thrive. And a therapist can do a great deal of being supportive and warm and giving feedback, not primarily because the patient needs that, but primarily because he can't stand, as it were, the heat of the negative transference. And it's really no service to the patient if the therapist is having to prove to himself that the patient is wrong in his perceptions of him. So I guess probably from your point of view, I would, in my work with these patients, I would probably be seen a lot of the time as pretty emotionally starving of my patients. I think probably that's true. I would caution you that a silence, of course, I would just more by way of reminder to you, that a silence needn't be emotionally depriving at all, that it can be the most conveying of warmth and love and so on, than far more than words can do. But it's indeed, some kinds of silence are that.
So-called good mothering, the technique of being supportive, is of limited use in the treatment of the borderline patient because it tends to increase the patient's guilt feelings about being unable to be supportive and confirming. Lack of supportiveness, seen by some clinicians as being emotionally depriving, can actually avoid the intensification of this guilt. The therapist is cautioned against leaping into supportiveness to avoid the heat of the negative transference. Another controversial issue in therapy is the use of personal revelations by the therapist about himself to his patient. Dr. Searles elaborates some pros and cons.
Now here's one. As far as I know, you encourage in some cases and at some point the sharing of personal feelings on the part of the therapist with the patient. You do not encourage the therapist to divulge to the patient personal events, feelings in the therapist's life, such as events and feelings about one's own wife or husband, children and friends and so on. What do you base this omission on? Now, that's an interesting question. I don't regard it as an omission exactly. I think it's unwise to get into much about one's own life because it's so hard to know where any natural limit would occur. And another of the complexities of that is that it rapidly becomes ambiguous as to who is the patient and who is the therapist. And if you're working, as I do, with quite a lot of people who are professional therapists anyway, it gets awfully difficult to keep clear that it is mainly the patient's life which is being explored, and the thoughts and fantasies I have that seem to be pretty much a function of the patient's life, that's a different and more appropriate kind of thing to share with the patient than stuff from one's, quote, own, unquote, life outside the sessions. Now, I don't think that one need be completely close-mouthed about one's own life, and I think particularly if the patient senses that something is going on in your life, I think it can be a very good thing to acknowledge that this is that there are matters on your mind that seem to you primarily not related to this situation, but that are drawing your attention somewhat away. There's some tactful way of acknowledging that some of your life is lived outside the office, but I think you get onto very shaky ground if you start telling the patient much about it. For one thing, it tends to have a very patronizing sound either when I've done some of that or when I've heard of colleagues who've mentioned about having done that. It's as if it's usually done in a very narcissistic way, as though you're giving the patient a great big break to get some little bit of glimpse into your own personal life. And I don't think very well of it. I'm uncertain about this because in a number of instances in the past few years, I have told patients more about my personal life and background than I used to 10 years back. And I think I'm really still in a stage of trying to get worked out in my own mind how much of that is appropriate and aids the work, and how much of it is most unwise and blurs the main task you're there for. But it is a different kind of data. I think if you have the patient in mind mainly, and the transference in mind mainly, and the patient's past history, best of all as it is revealed in the transference, you're not going to do harm by reporting thoughts and feelings that seem to you to be filling in blanks in the patient's life history.
Revealing personal information about the therapist to the patient is usually considered dubious business by Dr. Searles. If considering this, keep in mind the patient's life history and the transference. Reassuring, gentle, confirming responses can be considered supportive while having some limited use. They may more often have an adverse effect, namely, to increase the patient's guilt feelings at being unable to be supportive like the therapist. Failure to be active in the session may be seen by the patient and some colleagues as emotionally depriving when it is actually not so. It is important for the therapist to withstand the heat of the negative transference without leaping into supportiveness. While personal revelations may sometimes be of value, for the most part Dr. Searles believes they are inappropriate because they dilute the boundaries between the therapist and the patient and may be seen by the patient as patronizing and narcissistic. Therapeutic Techniques, Part 3. Between Therapist and Patient, Communications, Compassion, and Considerations about the Couch. The following encompasses 3 subjects on the treatment of the borderline, discussed briefly by Dr. Searles. First, communication of the therapist's feelings and associations which occur during the session. Second, the feeling states of compassion, envy, and a yearning for psychosis. And third, considerations for the use of the couch and the drawbacks of sitting up. Dr. Searles emphasizes the value of divulging to the patient feelings and associations which occur within the therapeutic hour.
The matter of fear, in these demonstration interviews I've done, audiences a number of times have really regarded me as a terrible villain. The word splitting comes to my mind. I'd never thought of it quite that clearly before, but they would feel filled with a really truly Christian love for this poor, fragile, schizophrenic patient, let us say, and filled with an equally Christian hatred and detestation of this bully Searles, who had been confronting this poor creature, you see. And I've had that happen so many times, and I've been strengthened in that endeavor by the knowledge that the old Chestnut Lodge colleagues would commend me. They're with me. They know what it's like working more than 6 weeks with these schizophrenic patients, because most of these places I've gone to interview, they don't work with a patient more than maybe 6 weeks. Well, you can sustain a truly Christian love toward these difficult people. But anyhow, you see, I'm too, it's a kind of, I guess my paresis is showing, but I get too circumstantial. But I was going to say about the fear, one thing I've done in a number of interviews is to frankly tell the patient in these demonstration interviews that he scares the hell out of me. And you'd be surprised how refreshing that has been, because nobody's admitted that to the patient before. And it really can be an illuminating thing for him sometimes, because some of these people don't realize how frightening they are. And if somebody can confront them with it, they've got a chance to get some real help with it.
Harold, that's exactly what John Lyons was telling us here 2 weeks ago, the importance of sharing those feelings and information with people who've never been told that.
Yeah, one of the experiences I remember best in that realm occurred, it's 25 years ago now, with a patient who I think would best be called borderline. He was a patient at Chestnut Lodge for maybe a year and was much less ill than most of the other patients there. He was a big man, suave kind of a bird, great big fellow, and he'd had by now quite a history of psychiatric hospitalizations. And I never was his therapist nor his ward administrator, but I had to admit him to the hospital, or something that involved my doing a physical examination of him in a little bitty damn examining room. He and I were the only ones in there. And he sat up on the examining table. In the course of the examination, we were talking about something or other. He said, "How would you feel if somebody said this to you?" And he put his arms around me and said something. And I said, "Scared." I was scared as hell. And he was completely astonished. He said, "Scared?" And I said, "Yes, I'd be very, very frightened if anybody did that to me, you know." I suppose a kind of being devoured. It was more than a homosexual threat. It was a very primitive, a really devouring kind of a stuff. And this was very illuminating for him, because he hadn't realized that when this person whom he was describing, who did that to him, he hadn't realized that it had frightened him very, very much.
The value of the therapist admitting his own fearfulness is unmistakable. In addition to revelations such as this, Dr. Searles supports the therapist's sharing other feelings, which are stimulated or dissociated by the patient during the course of the session.
But in seeing the patient in my office, I am nonetheless more active than many people are. I'm more active than I used to be 20 years ago. I do really a fair amount of telling patients what I'm feeling and fantasies I have, particularly with the borderline patients. I do tend to share that kind of material. And what is the purpose in doing it? Well, the purpose is one of treating it as shared data as to what's going on in the patient. That's my reference point. I think I'm experiencing a lot of stuff that he is dissociating, that I regard as belonging to him, and therefore I'm trying to offer it to him and help him to accept it. And I'm also trying to use myself as a model of somebody who can speak of these matters, who doesn't have to hide away from them.
In addition to telling the patient that he is frightening, Dr. Searles encourages the therapist to share associations to the previous sessions.
I've mentioned before the large-scale amnesias in borderline patients' remembered life history. And it seems to me that this kind of thing is dealt with best in the context of the history of the treatment. That is, the patient's amnesia can be seen as applying now to the events of the previous week's sessions, for example. And the amnesias are resolved in terms of an increasingly good memory of what has been going on in the work. And in this setting, you can come to see where the patient's amnesia is serving defensive purposes as a way of warding off feelings of hurt or unusually great anxiety or rage or whatever. Uh, and I've found it of interest as to when, in the course of a session with any one of these persons, at what point I will be reminded of something from the previous session. And I think it's just one of the innumerable little things that would make interesting research studies, really, for the therapist to try to notice at what point in the course of a session does something from the previous one occur to him. Maybe imaginably nothing will throughout the session, particularly because in the work with these patients seems often so discontinuous and one session not at all readily relatable to the preceding one. But more and more, as I get freer to report to patients what I'm feeling in sessions, I become relatively comfortable at saying to a patient, when you said that, or I was reminded, your saying that reminded me of something from the previous session, and I will tell them what it was I was reminded of. And more often than not, this kind of association isn't only in my own mind, but potentially in his too, and it's simply one way of helping the work to become more coherent.
It can be quite illuminating and helpful to the patient for the therapist to divulge his fears of the patient, feelings precipitated during the interaction, and any associations to the previous session which occurred during the current hour. This shared data gives the patient an opportunity to know how others experience him. It serves to model that it is okay for such things to be spoken about, and is based on Dr. Searles' belief that these reactions in the therapist are really the feelings of the patient, which have been dissociated or split off, and which Dr. Searles sees as belonging to the patient. In Part 2, Dr. Searles comments on the meaning and place of compassion, suspense, and envy in working with the borderline patient.
That state of simple compassion, well, I would say it's fellow feeling. It's a feeling of pity, but pity without condescension. It's a feeling of pity felt on the same plane, pity towards someone who is feeling what you yourself have felt in the past. It's a feeling that has had to do with the ability to forgive oneself and to accept one's own limitations and failures and all that. And it's a feeling that takes into account that the patient is being not simply the object of your love, but the patient himself is in allowing you to feel compassionately toward him is also confirming your own love, and that is that it's free of a patronizing kind of quality, and it's a feeling that doesn't require any physical accompaniment. It doesn't require you to touch the patient and to comfort her or him or to hold the patient's hand. It's the feeling in itself is enough, and I think it can be conveyed in silence. I don't think that anything needs to be said, really.
There are other feelings for the patient which command Dr. Searles' interest. Specifically, the therapist's feelings of suspense as to whether the patient will be driven into psychosis or suicide.
Related to this issue of suspense, the suspense as to whether the patient will become frankly psychotic and maybe lifelong. That's the way it tends to appear, at least, where the hazard is. The therapist spends so much time trying to help the patient to avoid that outcome and trying to help him become safely drawn back from the brink of psychosis, and feels so helpless so much of the time in his attempt that and feels the hatred of the patient so much of the time too, that the therapist can't help but wish that the suspense in the situation would be relieved, even if only by the patient's becoming frankly psychotic and out of the therapist's hands. You see, I think this kind of thing may well have been at work in various of these patients who came to Shepherd Pratt from having been in treatment with various private practitioners. Now, as to the therapist's yearning for psychosis himself, the gratifications that are to be seen in the borderline patient's ways of functioning, borderline schizophrenic ways of functioning, are very considerable gratifications. Such a patient makes one feel that segment of the world's population that is not crazy or borderline psychotic is terribly empty, conventionalized, dull, colorless, and so on. And the borderline patient often does seem to the therapist to be leading a very much more exciting and interesting life than the therapist himself is. And so it's in this kind of realm, through the therapist coming to feel envious of the gratifications he attributes to the patient's way of living, that the therapist yearns to become psychotic. And so that the therapist's attempts to save the patient from going more deeply into a psychotic kind of existence, if the attempts are really desperate attempts to help, they are apt to be serving as a defense against the therapist's envy of the patient for these sickest aspects of the patient.
We see then that the therapist can be profoundly moved through a spectrum of feelings, from compassion to suspense, and a yearning for relief from the burden of worry about the patient, to envy and a yearning to become psychotic oneself. In Part 3, Dr. Searles responds to a question from a clinician touching off the discussion about the use of the couch.
What are the implications of using the couch for borderline patients as opposed to a seated position? The borderline patient is usually thought to be in such poor contact with reality that it tends to impel him toward psychosis if he uses the couch rather than sitting up. Now, that's not as hard and fast a kind of rule as I make it sound to start off with. But that's the main reservation, I would say, about using the couch in the work with a borderline patient. I have seen that, and I've written about this brief point, that when in the course of the work the patient does start using the couch, there are separation phenomena to be dealt with, not only on the patient's part, who misses the degree of feedback he was getting from the therapist, but there are also separation phenomena on the therapist's part, who misses the vivid feedback he's been getting from the patient's facial expressions. And so that it's a real wrench for both people when the patient does start using the couch. Now, as to the sitting up position, this is another thing that my ideas and impressions are very much in a state of flux about these days. It's the borderline man I worked with for about a year, who early on had suggested I get contact lenses, was a very interesting person, and he sat up the whole time. And I saw him most of the time. It was once a week. He was not able to afford more than that. And he made me feel schizoid in the extreme. It's relatively easy for me to feel schizoid, even under fairly benign circumstances, but I sure felt it with him. And he was a very articulate man, and I think in Kleinian terms, he put his more schizoid aspects into me in the course of the session. And I've seen that happening time and time again with borderline patients. But I felt something like a clothing store dummy sitting there in the chair, set apart, feeling very much set apart, and felt odd and irrelevant to the situation, while he went on talking articulately and very rapidly. Now, in this sitting up position, he, like other patients, was very watchful of my facial expressions. And here we get into one of the, or I'm already well into some of the drawbacks of the patients being allowed to sit up. Because they will study your face all the time, and they may ask you what you're thinking. And I've made the mistake many times of telling them what I'm thinking. Now, it isn't necessarily a mistake, but it's very easy to get making a lot of mistakes in that realm, because they tend to give you to feel, well, the turnabout is fair play. They're asked to say what they're thinking, so why shouldn't you be asked what you're thinking? Well, you can't go far with that kind of thing. The therapist is filled with confidential material and can't talk about all kinds of things. But you tend to get led into making premature interpretations in the interest of candor. So the sitting up position has its drawbacks too, and I would tend to have most borderline patients get using the couch really. This once a week kind of treatment, maybe not, but twice a week, I'd get thinking more and more of their using the couch.
Traditionally, the use of the couch with the borderline patient is thought to impel the patient toward psychosis. Dr. Searles is appreciative of the drawbacks and discusses the pros and cons. The sitting up position can lend itself to making premature interpretations because the patient studies the therapist's facial expressions and asks about the therapist's thoughts. If, during the course of treatment, the patient makes the transition from the sitting up position to the couch, both the patient and the therapist should be prepared for separation phenomena to occur. Separation anxiety and wishes to be rid of patients. Sometimes in the course of treatment, interventions are made by the therapist which are born out of fear of the patient. Fear that the patient might leave treatment because of the heat of the negative transference may precipitate premature attempts at need gratification. This separation anxiety is frequently suffered by both the patient and the therapist and has diverse implications.
The one aspect of that topic that you bring in that has interested me a great deal is the separation anxiety, the chronic separation anxiety which the therapist lives in his work with borderline patients especially. And the patient's separation anxiety is usually something the patient is able to speak of, and the patient may tell the therapist that the patient, is afraid that the therapist will abandon him, will kick him out of treatment, as people in his past, including therapists, may well have done. And the therapist tends to try to behave in a generally implicitly reassuring way toward the patient in this regard, but meanwhile sweeping under the rug his own separation anxiety, that this unstable and unpredictable patient whose interpersonal relations have been so transitory in all probability will suddenly leave him. And not only the real financial risks that involves for the therapist in these days when patients are increasingly scarce to come by, but the emotional loss that this will mean for the therapist. So that it can be a useful thing for the therapist simply to become able to acknowledge to himself that he is living in a pretty chronic state of a high degree of separation anxiety in his work with the patient. Now, if the therapist can get to that point of realizing that, then he can start asking himself and keeping an eye open for answers to the question of to what extent is his fear that the patient will leave suddenly based upon an underlying rageful wish to be rid of the patient. And I think you can be pretty sure that a lot of his separation anxiety is on that basis, that he's having to swallow so much of his own anger and rage toward the patient, his own wishes to be rid of the patient, so that he's bending over backward to try to be solicitous and helpful enough to the patient, to keep the patient in treatment. And if he can get that much hold on the situation, I think that you've pretty well got that problem as much in hand as you can with these people.
The wish to be rid of the patient may manifest itself in acting out in the patient, sometimes through the development of a psychosis leading to hospitalization.
I would recommend that we keep in mind that the development of the psychosis probably indicated that something was amiss in the treatment, that it wasn't only the illness that the patient brought in and that blossomed out and became so severe the patient had to go into the hospital for a time. Maybe so, but it's very likely that the treatment was proving to be, in a sense, bad for the therapist as well as the patient, and that it was an inordinately upsetting situation for both participants, and that the therapist would tend to have very strong wishes to get rid of such a patient. I know I would, and I believe that we all would have wishes like that to cope with. And I think that that's part of the kind of feelings that need to be kept in touch with if you do elect to go on working with the patient. I think that you get into an untenable position if you try to behave in terms that you are the patient's therapist through thick and thin, and no matter what happens, you will go on being the patient's therapist. That sounds like a laudable goal, but the poor devil may have to cut his throat, you see, to get away from you if you get too caught up in this kind of dedication thing. It's I've been about as dedicated as anybody can be, and it can be a pretty diabolical thing, and if you're conscientious enough about it.
If the therapist dares to reveal his own separation anxiety and faces the wish to be rid of the patient, considerable gains are possible for both individuals.
Well, I will say that practically all patients who work with me are afraid I will suddenly quit with them. I think that's got to be an aspect of the way I am. I'm just the kind of person you just don't feel comfortable with. You really don't feel comfortable with. And it's kind of sad, but I'm 60 years old, and I guess I can accept that reality of myself, because every single last one of these poor devils is afraid that they are especially unpleasing to me, and that they're the lowest one on my totem pole and nearest to getting booted out. And I haven't really ever told any one of them that, really, and it would be a great kindness if I did. But I have told some of them. That's a pretty general fear. I have told some of them. Now, I was trying to get to some point. This serendipity stuff keeps throwing me. But so these patients are, I have told a number of patients, in patients with whom I'm having this chronic separation anxiety myself, that I had the fantasy that they wouldn't come today to the session, nor hereafter, that I had been, that the previous session, you see, I'm saying this, it isn't simply a fantasy of mine. I'm trying to tell them something of what I feel really did happen the previous day, that the patient left in a state of so much anger and rejection of me that it gave rise to even more separation anxiety on my part than usual. And I'm trying to share with these patients something of how insecure one feels in trying to relate to them, and the fear one has that one will be abandoned by them. Now, sometimes that revelation by me to them goes over very well indeed. In a number of instances, they are not that aware of their inclination to quit treatment, and they tend to assume that it must be that I want rid of them. And I've already told you that there's apt to be truth in that realm too, but I think that it can be a very useful thing in working with these patients to, at some time or other, in a well-timed way, to make known to them the fact that they keep you chronically in a state of anxiety and insecurity thank you, as to whether they will abandon you. Because that's a useful communication to them. There's a lot of reality in it, matter to you, emotionally.
In the therapist, fears of abandonment by the patient to be rid of patients because of pent-up anger. Sharing the separation anxiety with the patient may be ego-enhancing because the patient learns how insecure others feel in relating to him. It may bring to consciousness the patient's wish to quit treatment, and it demonstrates to the patient that the therapist is attached to him. Shared data such as this is based on Dr. Searles' belief in the notion of bilateral dependence. Strangleholds on the therapist, failure to leave the office, phone calls, and panic reactions. Working with the borderline patient can become burdensome to all therapists at times. Not only do we face particularly stressful moments of helplessness and confusion, but also significantly experience the feeling of being caught in a stranglehold by the patient. We join Dr. Searles answering this question from the audience. Under what circumstances have you found yourself unwilling or unable to tell a patient that your hands were indeed too full?
That's a difficult one for me to answer. I think patients get the sense pretty accurately that they've pushed me to the limit. When I start sighing heavily and anxious, large sighs, and drumming on the lamp pole, and being more testy than usual, maybe. I think about the limit setting, the more explicit limit setting as far as phone calls go. That I don't usually have trouble, though, in that area anymore, like I used to years ago, in letting patients know that I simply can't cope with phone calls between sessions, essentially. I used to, but I just can't do it anymore, or won't. I can't say anything really about that. It's anything of any particular interest. To let a patient know that one's hands are indeed too full. I would think there again, to keep the transference in mind, that it surely is no coincidence if the patient is making one feel like an overwhelmed parent, that there must have been one in the patient's past whom one can refer to and endeavoring to interpret while limit setting concomitantly.
In countertransference and related subjects, Dr. Searles writes, limit setting is one of the major dimensions of therapeutic technique in this work. Demands, whether verbal or nonverbal, upon the analyst are intense, tenacious, conflicting, and above all, are backed up by the implicit threat, inherent in various forms of negative transference to the analyst, that if he fails to meet these demands, then he fails to qualify as a human being, but is exposed instead as being a heartlessly sadistic, non-human monster. Dr. Searles talks further about his own limit setting with the patient when asked the question, how do you understand the patient's failure to leave the office at the session's end?
There's one borderline patient I see who makes me feel so irrelevant, superfluous, that when the end of the session comes, I feel that I'm having to muster so much brass in ending the session that I feel I'm earning my entire fee right there in doing that. Now, the connotation being, how could I possibly have the gall to end the session, you see, without my having said usually a single word? And now it may be that some patients that you were speaking of who have trouble leaving the couch, that could be one of the determinants of it, that they may be feeling that what they have produced is so thoroughly worthless that they can't leave after so lamentable a performance.
What can be done about the patient who is so upset at the session's end that he cannot pull himself together to leave the office?
That does happen to me sometimes, and I regard it with great seriousness because I have to see my next patient, and I have a very punctual, I brag some about my borderline qualities, but know that I'm an obsessive-compulsive pedestrian from stem to stern, really, for the most part, and my schedule is sacrosanct. And in fact, late one afternoon in a usual 12-hour day, as the next patient came up the corridor, I had a sense of living in a gigantic machine of my own creation. All these so if a patient won't get up from the goddamn couch at the end of the session, the whole machinery is going to... In other words, the world will stop. It gets around into my more catatonic dynamics now.
This is when that steel ball bearing comes into play.
Yeah, that's right. But I do regard this with great seriousness. And patients get up off the goddamn couch. They know that it upsets me, that it angers me, that it's a really jungle warfare type situation you've got on your hands. And
you tell them that they only rented it, they didn't buy it?
And what else do I do? Well, I don't know. I guess I get the message across to them that they're supposed to leave. Now, what if they don't leave? What if after all that, they don't leave? Well, my thought is that I would leave. I would be very glad to turn the whole damn thing over to them. And with at least one of them, I'm sure, and I think probably one or two, I have told them that if they don't leave, I will turn the whole thing over to them. It's I don't know realistically what you can do about such a situation. I think that if the patient is using the couch and that goes on, then it's a serious question whether the patient should be using the couch, whether they should be sitting up. And I think as a simple punitive measure, if for no other, I would start suggesting maybe it would be well if the patient resumed the chair rather than the couch.
Next, a question from the audience stimulated the following discussion on the power of panic to paralyze the therapist and threaten to bring about a therapeutic impasse.
This patient who is immobilized when flooded or overwhelmed with emotions and has no outlet for the expression of them. My best handle on that kind of situation is to think of it in terms of having a very important interpersonally controlling aspect. That is, I think the therapist, in working with such a patient, tends to feel increasingly constrained and unfree. And I think that the patient's feeling immobilized tends to get conveyed, or as the Kleinians say, put into the therapist. And I think that that's a necessary part of the treatment process. And I think that it needs to be resolved at an internal level in the therapist before the patient can become liberated. And now John Cameron, who's research director at Chestnut Lodge, really has essentially taught me that way of looking at things many years ago. In this instance, I would think the therapist would tend to feel increasingly immobilized and I would hope increasingly aware of the hostile controlling aspect of that is among the patient's motives, and that the therapist would find that her wish to help is opposed by a determination to live and to be able to function, and to go ahead and function in the session and let the patient adapt to that. Now that sounds brutal and maybe ruthless, but it is a liberating position that is very hard won for the therapist, and would come after a lot of anguished attempts to help the patient, such as the therapist is evidently involved in now. I do emphasize that the patients who are prone to panic, and I see this more and more in recent years, that when I encounter a patient who seems inclined to be close to panic, I'm very, very much struck by the interpersonally controlling aspect of that. It's a kind of stranglehold upon the therapist. The therapist is supposed to watch his words with inordinate care lest the patient panic. And that's a very, very offensive thing from the therapist's point of view. And I don't know any simple formula about this as with the other things. But I have the strong notion that the therapist who wrote this note is not sufficiently cognizant of the probability that her panicky patient, who is so ready to feel overwhelmed, has probably got her by the throat and is chronically overwhelming the patient, overwhelming the therapist. And I think it's unpleasant to see our patients' more hostile motives, because we don't want to think there are such nasty people in the world.
Dr. Searles discusses situations in which the patient tests the limits of the therapist, often provoking anguish as to how to respond. First, the therapist must acknowledge and accept his own limits. Then, as Dr. Searles states in his book on countertransference, Quote, "To the degree the analyst can get in touch with and remain in touch with the whole range of his own emotional equipment, he will be in an optimal position to establish and maintain such limits upon the behavior of the patient as are needed in the course of the latter's treatment." Common arenas for the strangleholds on the therapist are phone calls between sessions, panic reactions and threats of suicide, and leaving the office at the session's end. Panic and immobilization in the patient are seen by Dr. Searles as interpersonally controlling and expressing of hostility. Helplessness, self-doubt, and feeling irrelevant. Problems of the therapeutic symbiosis. The process of mutual dependence or therapeutic symbiosis is often the basis for the patient to make the therapist feel helpless, irrelevant, uncomfortable, and self-doubting in working with the borderline patient. Dr. Searles prefaces his discussion of these feelings of helplessness with a few thoughts on therapeutic symbiosis, felt oneness, and the terror this experience may precipitate in the patient.
How do you work with a person who is terrified of his or her own wish to merge, fuse, and where this experience will be important in their recovery? This experience of what I would call therapeutic symbiosis. How would one deal with a person who is terrified of letting any such kind of oneness, felt oneness, supervene? Among the bits of data in these folders is one patient who was terrified of fusing with her mother, and the thing that dawned on me in the particular context in which the patient was speaking of this is that I realized what a terrified person the mother evidently was, or at least in the patient's view of her, such that it was when the patient's terror would reach a particularly intense degree that the patient would feel that she was becoming her mother. That is, it simply told me that this is something of how terrified the mother was, or at least in the child's experience of the mother. And I simply found that a kind of illuminating way of looking at some of this. So that if the patient in the transference is terrified of his own wish to merge or fuse with the therapist, it may well be on a similar transference basis that the therapist is being reacted to as a terrified mother, terrified from whatever sources, and hence that for the patient to merge with such a mother in the transference would realistically, supposedly, would be a terrifying thing. So maybe what would be needed is to get looking at the question of whether the patient is reacting to the therapist as being terrified, and it now occurs to me that the patient might, under those circumstances, suspect that there might be a paranoid note in the transference, that the patient would suspect that the therapist is trying to promote this fusion as a way of finding refuge from the therapist's own terror, rather than as something that is beneficial for the patient.
In 1971, Dr. Searles wrote, quote, "As the months and years of the analyst's work with the autistic patient wear on, the analyst is given to feel unneeded, incompetent, useless, callous, and essentially non-human in relation to his so troubled and beseeching and reproachful, but so persistently autistic patient." We join Dr. Searles at a point in the dialogue where he is commenting on the therapist's sense of helplessness.
Borderline patients are capable of making us, as I'm only saying these, I'm sure this is no more than a reminder to you. You know these things. I'm reminding you, I hope, of some of these things you already know. Borderline patients are capable of making us extremely uncomfortable. And we don't want to feel and know ongoingly that patients are able to make us so darned uncomfortable that it's a real question whether we're capable of working with them. It's traumatic to our narcissism to face the question of whether we may have encountered somebody who simply has more going on inside him than we're able to help him with. So we want to kind of whistle past the graveyard, but to the extent that we do, you see, we aren't helping him where he most needs the help. I think I'll desist on that for now.
Well, you're stopping just as you're getting to the therapist's helplessness.
The therapist's helplessness. Well, I had some thought that patients are more accepting and really charitable of us in our limitations than we give them credit for being. And I found I wanted to turn away at that point. I think I get sentimental maybe, but I will go on a little further because borderline patients really do, and Milton touches on a very important aspect of the thing here. I think borderline patients do need for you to reach a point where you acknowledge in a fairly open way that you've got your hands full with them. That is, I remember Frieda from Reichman speaking about schizophrenic patients, saying that if the therapist endeavors to maintain an imperturbable position with them, and the therapist does try often to present a relatively calm demeanor. He's, I guess, on the theory that it's best that only one person be tearing her hair out, so that you do kind of emphasize the calmness. But as Frieda said, that patients find this very provocative, and they won't rest until they can do something that will require you to show how upset you are, how angry you are, how jealous you are, whatever you may be. And similarly, borderline patients will press you until you knock off the kind of omniscient and imperturbable stance. But once you are able to do that, I think they are pretty about as accepting as anybody else of the fact that you have your times of great helplessness. They know they are very, very difficult people, and I think they tend to cherish somebody who is candid enough to acknowledge that all he can do is the best he can do, and that he knows what failure is, because surely these people know what failure is.
Self-doubt is an experience known to every experienced therapist. But the kind of self-doubt triggered off by working with the borderline patient has a unique quality of its own. Speaking from personal suffering due to self-doubt, Dr. Searles comments on a clinician's inquiries about his own work.
It strikes many a chord in me as you talk, and I'm reminded of how when I get involved in a lot of self-doubt in my work with a patient, some superego figure from the past is, as it were, looking over my shoulder, something of that kind of feeling. And it isn't quite that anymore the past few years, so much as it is some kind of idealized concept of what a classical analyst would say one should do in this situation. And I find that I tend to be more oriented toward my conscience, externalized in that fashion, than I am toward the patient, really, a lot of the time. I'm trying to propitiate some damn chunk of superego like that. And I think that probably if we could know enough about our patient and his family history, we would probably find that even that divided state within ourself fits into his family history, that this is just about how self-doubting his father once was or his mother once was, something of that sort. And we imaginably could report much of that to him to see what it brings to his mind. You sound concerned about what the colleagues would think. And I think it's always interesting and to be wondered, what does it mean when we become concerned with that, as we always do from time to time, all of us. We get very much, in that sense, it's as if they're more than just the two people in the office. That there's some kind of taking flight from intimacy, I think, is probably one aspect of it.
It is not a large jump to move from feelings of self-doubt to feelings of irrelevancy. Let's remember that the borderline patient is particularly skillful in propelling us along this road. Dr. Searles relates to this feeling irrelevant first with a focus on the work with a narcissistic personality.
Is there a difference between, this question went, is there a difference between the narcissistic personality and the borderline personality? Again, it's such a matter of semantics. The way I think of the terms, anyhow, is that the narcissistic personalities are one of the sub-varieties of borderline personality. I might spend a few minutes talking about narcissistic personalities. I make a lot of mistakes in working with narcissistic personalities because I keep forgetting that in making interpretations, the interpretation should be in terms of different parts of the patient's self as being of the area relevant for him, that he's not worried about what your opinion is of him. The interpretations couched in such terms are just not useful to him, but he's concerned about his own opinion of himself, so that if your interpretation is put in terms of, are you afraid that if you do such and such, your stature will be diminished in your own eyes, this is at least a sensible interpretation to him. But if you say to him, are you afraid that if you do such and such, I will think less of you, it's very much like a flea saying to an elephant, are you afraid I will think ill of you? It's just, it doesn't make any sense. And I think my own narcissism is so abundant that I can't comfortably assume this flea position, and you know, I keep thinking that I'm important to these patients, and I'm just not yet. Not this decade, not yet, but another few years maybe, but not yet. And well, so that's one thing. Now, I worked with a quite narcissistic man for quite a long time. Not a terribly long time, but quite a while. And he used the sitting up position, and I used the sitting up position. And felt really that I was being shafted most of the time, and not in an entirely gratifying way either. It was, I felt irrelevant. I kept wanting to say to him, why are you telling me this? I'm sure, I would hope that this kind of thing strikes a chord in many of you, because I think this is one of the most familiar kinds of so-called countertransference feelings we have in working with borderline patients. They make us feel so irrelevant. They make us feel, well, that these things you're talking about are important things, to be sure, but you could as well be saying them to a neighbor or a friend or a co-worker. Why are you telling me this? Why are you telling me this? And this man spent, this particular man spent nearly all the time, it seemed to me as I sat and listened with my third ear to this, he spent nearly all the time telling about what a great guy he is, hour after hour. And then I began to see that, and I think that I began to see it because it was emerging. I don't think it had been so present at the beginning. I began to see that in his talking about this great guy, he was, as it were, talking in the third person, that this guy was someone other than him, like a very greatly admired other person.
Dr. Searles moves from a focus on a narcissistic personality to describing some of his feelings in working with a borderline patient.
He made me feel schizoid in the extreme. It's relatively easy for me to feel schizoid, even under fairly benign circumstances, but I sure felt it with him, and he was a very articulate man, and I think in Kleinian terms, he put his more schizoid aspects into me in the course of the session. And I've seen that happening time and time again with borderline patients. But I felt something like a clothing store dummy sitting there in the chair, set apart, feeling very much set apart, and felt odd and irrelevant to the situation, while he went on talking articulately and very rapidly.
Dr. Searles has focused our attention on unpleasant feelings which arise in a therapist during work with the borderline patient. It is important for the therapist to know that such feelings are bound to occur as grist for the mill because of the process of therapeutic symbiosis and the blurring of identity of the patient and the therapist in the patient-therapist relationship. Splitting the transference. Questions about endorsement in the case of group psychotherapy and psychopharmacology. The so-called therapist-administrator split has been the subject of heated debate by clinicians in the field for many years. In work with the borderline patient, in whom the defense of splitting is so prevalent and troublesome, Dr. Searles questions the endorsement of splitting the transference through the use of more than one therapist, either with the addition of a group therapist or with the addition of a therapist to oversee psychotropic treatment. We will join the discussion as Dr. Searles is asked the question.
She questions Dr. Searles' point of avoiding the splitting of the transference in view of our start in life with split transference and its continuation intermittently throughout life.
Yes, this is it's a very perceptive question. I felt a little uncomfortable with this talk about avoiding this split transference. Now, I acknowledge that life is full of transference figures for us all to some considerable extent, and surely for any of our patients, that the transference isn't something confined to the therapeutic relationship, but the patient is involved in intense transferences to other persons, present and past, in his life, and these are not to be avoided by any means. But I do think that it's quite questionable if the therapeutic situation itself is set up in such a way that the therapist gives his endorsement and seal of approval to the separating off of the patient's transference to, for example, some group therapist. I don't know that that's a bad thing, but I think it's a very questionable thing. It's worth questioning about, because the patient is apt to rightly feel it that he is supposed to take large realms of his feelings elsewhere, that this is the therapist's wish. I'm not sure I can say anything more than that about it, really.
I would just like to affirm your last position and speak as a group therapist for many years, and that is, in my own experience, although there have been times, and I've tried all methods, that I have worked with patients who were seeing another therapist for the individual work, I would say that almost 90-odd% of the time it has not worked out to anyone's benefit.
None of my patients at the present time is in group therapy, and I don't think I've had any, I have not done group therapy myself in probably 30 years, except for some family therapy I did at NIH in Lyman Wynn's section, and he was doing the family therapy of schizophrenia research project, and I worked with him twice a week in family sessions over probably 6 or 7 years. And we had a series of 3 families, one of whom was about a year or 2, another a year or so, and one of them about 4 years. And so that ended probably 10 years back. But that did give me a moderate measure of experience in the group setting. I don't do group therapy myself, and have often wished in the past dozen years that I had the venturesomeness to branch out into it, because I think it has a great deal to recommend it. As for the idea of my doing individual therapy with a patient who is in a group with someone else, I'm leery of that, but wouldn't forbid it from my point of view. I'd like to see how it worked out. Again, I'd be concerned about the splitting of the transference, particularly with borderline patients who are so given to splitting anyway.
Are you one of those who, like myself and many others, certainly doesn't operate on the premise that transference as a concept is primarily to be locked in with a therapeutic situation, but rather it's occurring in our lives all day long and throughout life?
Exactly, right. Now, as Milton talked, I got reminded of the position I found myself in more than once, where I was working with 2 persons who were friends or co-workers, and the enormous ticklishness of that situation I'm sure you're familiar with, and I'm sure many of you are, but it's an extraordinarily difficult situation where you have to be meticulously careful not to breathe a single word to patient A about patient B, or you get so you can't even breathe a single word in response to patient A about something he has said, you see, about patient A, any kind, because of the fear that it will get carried back to the other patient in a spirit that we were talking about you. You see, if they can quote the damn analyst in any way, it's really, and I somehow get the sense that the patient who's being in individual therapy with one therapist and in, say, a group therapy with another therapist may feel something like the constricted kind of feeling that the therapist has when he's working with 2 people who are friends of one another, let us say. I don't know that there's an inherent connection there, but I suspect that there is.
Similar to the problems precipitated by the situation of having 2 different therapists is the situation of having a separate therapist to dispense medication when it is used concurrently. Dr. Searles is asked to comment on his thoughts about drug treatment with the borderline patient.
What is the role of psychotropic treatment, that is drug treatment, with a borderline patient? It's, again, a very, very large and important topic, and I do not dispense drugs in my own work, and some of my patients get medication from one and another source. Maybe they're internist. Usually they're internist, and I don't object to their doing that. These are people I see once a week, maybe twice a week, usually once a week. If I were seeing them 3 or 4 times a week and they were doing that, I think I would start bringing pretty steady exploratory pressure to bear as to why this was necessary. But if a patient is able to afford treatment only once a week and is rocking along in some fashion or other as best she can, if she has to get a bit of Valium from her internist occasionally, this does not upset me. Maybe it should, but it does not. Now, I cannot imagine trying to treat patients in psychoanalytic therapy if I were at the same time dispensing medication to them. Now, it may be that many practitioners, fully as experienced as I am, do so. But for me, it's too much of a contradiction in terms. If I am being that much of a kind of reality gratifier, I would think that it would inevitably tend to drive the negative transference underground, because the patient would be, I would think, inescapably concerned to be relatively pleasing to me if the main thing they're wanting is a renewal of a prescription. Now, Peter Giovacchini, who, as you know, has such a very wide reputation in this field, has told me that when his patients use medication, he has a colleague who's psychoanalytically trained and a friend of his, well known to him, do the management of the dispensing of the drug and this seeing to the possible side effects, things like that. Maybe that's a very satisfactory way to do it. I don't have a colleague whom I would feel inclined to turn to for that purpose. I've thought of this many times. It has, again, always seemed to me pretty darn complicating for me. I can't see my way clear to it. I can say that at Chestnut Lodge, every patient there is assigned 2 doctors, a ward administrator and a therapist. And medication, which has come into being much more since in the era since I left there, is dispensed under the orders from the ward administrator. So they use this 2-doctor system there. They continue to with the matter of the drugs. But I think it's a very complicating business, the split transference that this would involve in private practice if your patient is going to two doctors for his treatment. I know of no easy answer to this at all, but I think that if treatment can be gotten onto a twice-a-week basis at a minimum, I think it's a legitimate aim to move away from the patients using drugs acquired from anybody. I think it's fair to say that that's one of my goals.
Dr. Searles has been puzzling about many questions regarding endorsement of the split transference situation in the treatment of the borderline patient. One such situation arises if the patient has a different group and individual therapist. Dr. Searles has no experience himself with this, since none of his patients are in group, nor does he do group therapy himself. Another split transference example is the therapist who supports the concomitant use of medication dispensed by someone other than himself. Dr. Searles does not choose to dispense medication in his own practice, primarily because he sees it as too much of a reality gratifier. The patient tends to get too concerned with pleasing the therapist in order to get the prescription, thus driving the negative transference underground. The cure, playfulness, and other signs of progress. The following discussion begins with Dr. Searles' notion of the meaning of cure, and proceeds to an elaboration of manifestations of progress in the treatment, such as playfulness and improvement in one or more characteristic borderline traits.
Well, let's say we're talking about borderline states. The definition of cure, even as applied to that area of the patient population, is a large enough question. Obviously, very difficult question to which I can make only as best answer I'm able to make. I immediately think of how any cure is partial. That aspect cannot be overemphasized, and I say that because I think all of us, when we first got into this field, we used to talk about wanting to get our analysis completed. And that's a very interesting idea. And it is possible to stop going to the analyst. That certainly is possible. But the idea of completing an analysis in anything like a final, thoroughgoing, no stone left unturned manner just is a million miles beyond the realm of possibility. That now, another thing that comes to mind is that our sickest aspects are always accessible to us. Another way of thinking of it is that our most primitive kinds of psychological functioning are not outgrown in the sense, in human development, are not outgrown in the sense of put behind us and never again recaptured. Far from it. There's what, Chris has described as regression in the service of the ego, which alludes to the fact that regression can and does and usefully does occur, that enables us to get in touch with these earlier, more primitive kinds of emotional experience, which certainly are of the essence for the therapist's intuition in working with his sicker patients, so that the therapist himself never has become cured of his conflicts, let us say. He's come to know them better. He's become much more conscious of them. He doesn't have to keep them relegated to the unconscious realm anything like as much as he once did have to.
Playfulness between the patient and the therapist has different meanings and forms in the various phases of the treatment, both in the phase of therapeutic symbiosis and in the phase of individuation. The meaning of playfulness is important for the therapist to appreciate, as is the quest for meaning in general. Dr. Searles clarifies both in the following discussion.
When the treatment has progressed to a point that the atmosphere is a playful one, you don't have to seek help from colleagues anymore about the treatment. It's going well. It's in kind of phase that I have labeled therapeutic symbiosis, where there's a great deal of fluidity of ego boundaries in a contented and trusting kind of emotional atmosphere, where it's no longer experienced as a threat that the relaxation of ego boundaries occurs. And there's a playful, I've thought of it anyway, gambling about in between the realms of fantasy and reality, and the erstwhile threat of craziness has been gone past. That they have worked through that and can now enjoy being playful. And something I want to mention about that aspect of the topic is that the search for meaning, which is something we all are interested in and are highly trained in, can be a remorseless kind of thing. And in a child, let's say the adult borderline patient, when he was a child, he had too early to be concerned with the meaning of things. The atmosphere he lived in had so much danger in it of various kinds that he had to develop wariness and a concern about what was the meaning of all kinds of signs and symbols and events. So that in the therapy, the therapist's attempt to ascertain the meaning of phenomena tends to have an inherently negative connotation for these people. And when the era of playfulness can supervene, one of the most delightful things about it is that there's a subjective freedom from any burdened concern about the meaning of things. the matter of meaning, it's in the paranoid schizophrenic patient where you see in the extreme form the concern about what is the meaning of things, and the whole emphasis on meaning and the search for it tends to have a really quite negative connotation for a lot of patients. I don't, of course, mean that the therapist should entirely put behind him any concern about meaning. Of course, he cannot. But I think it is well if we can grasp the idea that a baby and young child is very fortunate if he has had the experience of living in a home where there was enough assurance of love and caring so that he didn't have to become excessively wary and watchful and weighing of the significances, the meanings of things.
Could you share your experience with playfulness and the movement of the patient toward individuation?
I don't know that I can say very much about that, really. I have talked about playfulness mainly in this therapeutically symbiotic phase. Now, I do feel that that's a phase that precedes the phase of individuation. Now, playfulness that extends on into the pretty well individuated level of development, my mind turns to the matter of sexuality. That is, I can't think of speaking very playfully with a patient whom I'm regarding as really quite adult now and very much a separate individual without thinking in terms of sexual humor and jokes that have an erotic meaning. And I think that if the patient is sufficiently comfortable to be able to adapt to much badinage of that vein, that the work is pretty well over if the realm of sexuality has become that unthreatening to the patient. So that I don't regard it as any great problem, really, but it's rather that if they reach that stage, they're pretty well through treatment. Because up till that point, any playfulness that had much of any potentially lustful aspect to do with it is very, very upsetting to patients, as I'm sure all of you know.
In addition to playfulness, Dr. Searles has observed other signs of progress. A lifting of the large amnesic gaps, an improvement in the continuity of remembered life history, an integration of positive and negative feelings, and mutual development in the patient and in the therapist.
Now, another thing that occurs to me as regards the matter of cure, I have collected a fair amount of material documenting signs of progress on the part of borderline patients in therapy. This is, I'm speaking of progress, not cure in some final sense, but in speaking of these matters now, I necessarily get into what are some of the characteristics of the borderline state. And I'll be getting a little ahead of myself here, but that's all right. One of the signs of progress in movement toward relative cure in borderline patients is that the massive amnesias that are so characteristic of these people for large stretches of their childhood have lifted to a great extent, and the patient is able to survey his own life history in a continuous, seeing it as a continuous flow of events, and in a sequence which he did not at all discern in it when he came into treatment. The matter of coming to learn what had been the chronological sequence of of traumatic events in his past and important phases in his past is something that is a very hard-won thing, as I'm sure all of you know much of these things. Patients will come into treatment with these large gaps in their recollection of what went on in grammar school years, for instance, and will be able to remember separate incidents which they remember as having been very important, but they do not remember in what sequence these occurred. And I have learned to respect the patient's defenses, the necessity for him to maintain these areas separate in his life. I've learned to respect it through such incidents as in one borderline man I was working with, and I had worked with him for a number of years, and it occurred to me that two of the very important developments in his past that he had recalled, that one of them simply followed upon the other sequentially. And I simply told him that. And for several days then, I was afraid he would suicide. His suicidal proclivities had been in evidence before, but I had rarely found occasion for that much concern. And that taught me the lesson that he needed to keep those areas chronologically apart yet. I should have waited until he could reach that realization that these things had occurred in sequence. I'm reminded as I talk right now of Melanie Klein's description of the movement from the paranoid position to the depressive position. And I am no expert in Kleinian theory, but my understanding of it is that in her views, when the infant or young child comes to realize that the good mother and bad mother that prevailed in the split that prevailed during what she calls the paranoid position in very early infancy, when the infant or young child comes to realize that these two are really one, and that the good mother whom the child loves is also the bad mother whom he hates, and that this realization brings depression with it. So that this man I was working with, I didn't sufficiently respect his need to keep those incidents split yet. Now, I won't burden you much longer by trying to ruminate about what is cure, but it occurs to me that I would think in terms of the mutuality of curative effect in treatment. That is to say, I cannot imagine a patient getting into treatment with a therapist and the patient progressing to a very marked improvement. Not to say cure because it has such a totality and finality about it, but progress to a really very good therapeutic result without the therapists having also grown and thriven in some important way or ways also. And this is in keeping with my long time developed impressions and beliefs and convictions that dependency is not similarly a unilateral thing, but it's inherently bilateral in human relations, including the therapy situation.
Dr. Searles prefers to look upon the movement toward a healthier adaptation to life through a reflection upon manifestations of progress rather than the idea of cure. Signs of progress include the advent of playfulness in both the therapeutically symbiotic phase and later in the phase of individuation, the lifting of large amnesic gaps, improvement in the remembered chronology of life events, an integration of positive and negative feelings, and mutual development in the patient and in the therapist.